And now we'd like to welcome our final speaker of the day, who's been waiting patiently in the wings, listening to the conference, Dr. Harut Hovsepyan. Dr. Hovsepyan is a board-certified physician with extensive experience in emergency medicine, personalized patient-centered care and wellness, and longevity and addiction medicine. He completed medical school at USC Keck, where he received his master's in public health. He's a board-certified emergency medicine and addiction medicine specialist. Dr. Hovsepyan will be speaking to us today about addictions and their impact on mental health and suicide prevention. So let's welcome Dr. Hovsepyan.
I am not Dr. Hovsepyan, so I'd like you to introduce yourself, sir, and tell us a little bit about your background and experience.
Absolutely. First, I just want to give a quick shout out to Pierre and Marie in the background, who've been doing a lot of stuff for us. Thank you guys so much. And then also you, Robert, thank you for having me. And I threw a little, I have to admit, so I had this whole presentation written out and I threw it in the trash can this morning and I went to Robert and I said, let's just do a podcast style conversation between two professionals. And we're just going to go back and forth. This will be completely unscripted. I also just want to thank Purnima and Dr. Feldman and Dr. Siegel. I'm kind of a newbie here, so I just really appreciate you guys having me in the room. It's a real honor to be here with such professionals. Okay, so I guess have a very different background than most of the professionals here because I'm an ER doctor. And I just remember going to medical school, not knowing what I wanted to do with my life. I just was like excited, I want to be a doctor. I want to help people. It's so exciting. And kind of when I got into clinicals, I did general surgery. I loved it. I was like, I'm going to be a surgeon, And then I did pediatrics after at CHLA, which was awesome because I get to take care of kids. And I was like, this is awesome. I want to take care of kids. I'm going to be a pediatrician. And it just went on and on and on and on. And then, ER medicine is something you don't get to do until fourth year traditionally in medical school because, people sometimes ask like, what is that specialty? Like, what is ER, And I like to tell people that emergency medicine is the worst of every other specialty is our specialty, So if someone's a cardiologist, right? People know cardiologist, so it's the heart doctor, right? But when someone has a heart attack, they don't call their cardiologist and go to the office, right? They call 911 and they come to the ER and they see me. Or if, neurology, right? If someone has a stroke, they come to the ER. And so this kind of resonates because very much with, a very serious topic like someone being in such a dark place in their life where they're suicidal, it's not uncommon that they come to the emergency department and they see me, or one of my colleagues. And our job is, as the ER physician, is more to do the medical treatment side and stabilize them. And we have very amazing psychiatric teams that assess afterwards. And we work hand in hand, and it's a team sport. Emergency medicine is very much a team sport. And what happened was I kind of saw this cycle happen over and over and over again. And there definitely was a correlation with substance use disorder. And a lot of my patients are on illicit substances. It's not uncommon that they come to the emergency department and they need resuscitation. They need very powerful medications that we can give with IVs. And doing this for year after year, I asked myself, what more can I do to help these patients besides just be an ER doctor? It was just fascinating for me because the resuscitation part is interesting and use a lot of skills, but I would see familiar faces come to our emergency department over and over and over. And I really wanted to stop the cycle. And like so many things in life, it kind of just happened serendipitously. None of this was planned. If you asked me 2 years ago, I was going to be an addiction doctor, I'd be like, I don't know what you're talking about, But what happened was my a very good colleague of mine started a nonprofit where we were doing street medicine. And I loved the mission. And so I went to the ER a few days a week. And a few days a week, we had vans and a backpack. And we actually went to homeless patients all over LA County.
Wow.
And we brought the kind of, I guess I brought the ER to the streets, you know? And so we would have both their medical care, their mental health care. It was a little bit of everything, and their addiction care.
Mhm.
And, you know, it's sad to say, but over and over and over again, there was addiction, addiction, addiction. And that was tied to mental health, mental health, mental health. And so that's what led me to get board certified in addiction medicine and start my private practice where I do a lot of different services, including addiction medicine. But that's kind of the story of how that kind of evolved.
Thank you for that. You said a lot of really important things. When I worked in suicide specifically, they talked about one of the factors was addiction or substance abuse was involved more than 50% of the time, and that did impact it. So addiction is fascinating, the fact that you took it to the streets as well, because we do know a lot of the homeless issues and mental health issues are correlated to addiction. What specifically is it, do you think, that ties substance abuse to suicidality or makes it more likely to co-occur?
It's a loaded question. There's a lot in there, but for sure, many times when a patient uses illicit substances, they're disinhibited or not in the right state of mind. And if they have psychiatric disorders underlying on top of that, they're much, the studies show 5 to 10 times more likely to succeed in committing suicide versus a patient who is not using substances or has substance use disorder.
So when you're looking at addiction, what do you start with in terms of, so you're dealing with people that may be coming to see you as an ER doctor. How do you cut through their denial? How do you begin the treatment? What do you look at first?
Great question. So it can't just happen in the ER, right? This is the most important thing is to understand that this is a chronic disease. This is a chronic disease. Just like coronary artery disease is a chronic disease, just like hyperlipidemia, high cholesterol is a chronic disease, just like the ramifications after you have a stroke is a chronic disease. Addiction and substance use disorder is not something that just happened one day because of lack of morals or that person's a bad person. There's a lot of evidence in literature that shows that that's just not true. And we have to really have that mindset. For a long time in our culture, it was the criminal justice system that was policing substance use disorder. But I think it's important that we say this is a substance use disorder. And so the ER is one point of treatment. And then there's follow-up after. And that's very hard to do with how the system is in our country. So that's why I became board certified in addiction medicine and have my clinic. I really wanted to help these patients afterwards. And so I've been doing medication treatment. So I do some of my own psychotherapy as well, cognitive behavioral therapy. I do IV ketamine therapy, which has been very successful. I have a lot of patients on IV ketamine therapy who are doing really well. And try to push the boundaries of addiction medicine. And it's important to have those two pillars of good medication treatment and therapy and a support system. You know, it's not one or the other, it's all of it. It's all important. And meeting these patients with compassion and love and care rather than judgment or, oh, that, you know, that person's a junkie, you know, pull yourself up by the bootstraps and get it together. That's just not science. That's just not medicine. You know, so we have to really think about this as a disease, because that's what it is. It is a disease.
Very significant point. And I think as a psychotherapist, and as long as I've worked, coming to that conclusion, obviously, and then being able to convey that to individuals because of all the judgment, the stigma. When people approach you outside of the ER or come in, how do you help them understand the nature of the disease? And I think that also is a really important thing to say. How do you help them understand it is a disease? It is something, and what do you look at as terms of prognosis, helping them understand that it's chronic, I think is also significant. And what does the path of recovery look like for them? What do you expect? What do they expect?
You ask such good questions.
Loaded question.
I'm so glad I picked him. This is awesome. Another loaded question. You know, this morning, I really wanted to be here for the whole conference, but I actually had a patient at my clinic. My clinic's right across the street from here, and I had to see a patient this morning that I went to do an IV ketamine therapy session, who has been suicidal in the past, who has alcohol use disorder, very, very, very severe. Is a young gentleman with 2 children, in his late 40s. He drank 25 to 30 beers a day. He is a very, very high functioning accountant who actually is very successful, but he has a chronic disease. And he is in the brink of losing a lot. And it's really hard. And this didn't just happen from one single incident or episode. So the first thing I do with my patients is make sure they understand that they have a chronic disease, and I tell them that, and they appreciate it, because a lot of times no one has told them that before. They've been through the healthcare system with dozens of doctors, dozens of specialists, and I might be the first physician to say that you have a chronic disease, which is pretty profound. But that just shows just how young the specialty is, and it's kind of a black sheep in medicine when you think about it. When you think about the medicine itself has a lot of traditions, a very old craft, so to speak. So, internal medicine, family medicine, psychiatry, they've been around for a long time. Cardiology. The 2 specialties I have are probably the youngest specialties of the House of Medicine. Emergency medicine didn't become a board certified specialty until 1989, which is, a lot of people don't know that. But what happened was when John F. Kennedy got shot, people didn't know where to take him in the hospital, because a lot of these hospitals were not staffed by people who knew how to resuscitate and stop people from dying. And that was the beginning of where surgeons and internists kind of came together and said, we really need to have a doctor who knows how to handle emergencies. That's how, and the same with addiction medicine became a specialty in 2015. It's only been 10 years. Wow. So to have it as an actual specialty, so it just shows how young the profession is. And for a physician like me, it's super exciting, because I'm like, there's so much to learn, let's figure it out. So the truth is, the reason why addiction medicine is so difficult is because it's not, cholesterol's high, throw a statin. Coronary disease, give the aspirin. Psychiatry, addiction medicine, these are not easy problems, and I think my psychiatric colleagues would agree. It's not, we do have medication treatments, we do have pharmacology's gone a long way, but there's so much still we don't know about psychiatry. I'm not a psychiatrist, but I think you would agree with me that the human brain and addiction is part of that, because the interesting thing about substance use disorder and addiction is there's 2 sides. There is definitely the psychiatric side, and then you also have physiologic dependence. A lot of people don't delineate those 2 things, right. But there is the mental component, and then there's the physical component of your GABA receptors, your dopamine, your neurotransmitters, the receptors in your gut. Everything is off.
Mhm.
And then go to the doctor and try to fix it all. It's not going to happen with just one pill. It's not going to happen with just one therapy session. It's a journey, So I guess the most important thing I tell to all my addiction patients is the first time I meet them, this is the beginning of your journey.
Mhm.
I'm going to be with you. We're going to figure it out. There's going to be mistakes, and that's okay. And I think that's important. That's okay.
Yeah, no, I think that's really important. I was fortunate enough early in my training to work with my mentor who was in recovery, who the first thing she said to me as a psychotherapist is, you have to understand it's a medical issue and you need to share that with your clients. So we have a lot of therapists, friends, family members of people who may be dealing with addiction or are going to deal with it. How would they approach a client? They come in, they do their assessment. We know usually the client's not going to be totally upfront and honest because of shame and stigma, but you recognize the issue. What do you do to help them get through their stigma and shame? And do you recommend then that we as therapists or friends or family members say, we need to get you to a medical doctor as well as do the treatment?
It's a team sport, right? And you guys as therapists play such an important part, just as equally important, if sometimes not more important than even the doctor, but it's a team sport. There's certain skills I can offer, certain skills you can offer, certain skills family members can offer. And again, it's so individualized and everyone is so different. I try to not do too much talking the first time I meet the patient, to be honest. I let them, if they're lying or if they're not straightforward, that's okay too, because, as a human being, you can understand why there's some shame and guilt. And if you just provide patient-centered care and put yourself into their shoes, or like, imagine this was one of my family members, it makes total sense. So I just try to listen the first time, build rapport. And my motto is, you got to meet the patient where they're at, because I'm thinking more of like the long-term game for addiction medicine. ER is pretty straightforward. ER is dying, not dying, stop the dying, move on to the next dying, that's what I loved about it. That it was very linear in your thought process. And addiction medicine is the opposite of that, if the long-term addiction medicine, and unfortunately there is a point in the spectrum where the patient is dying and you have to stop the dying. But if you get them back, then you have to think about their long-term care. And that's complicated, that's difficult. That's a multi-year journey,
Absolutely. So due to the chronic nature and unknowing in terms of where a client or a patient may be when they come in and you don't even know yet if they're sober or the severity of the addiction. I mean, some schools of thought is tell them go to 12 steps, let them get sober and then come back. Some, like you may say, or I may think, take them where they are, see what you can do, see what treatments you can recommend. Some may say, write to you. How do we assess? So I see somebody and I think this addiction may be much more than I'm thinking. Do I start by sending them to you? I certainly, I don't like the idea that come back when you're, more ready for therapy, or, you can't do therapy until you're sober, or you have to show up for therapy sober. What are your thoughts about all of that?
Starting treatment as early as possible is life-saving. I think we have enough evidence now in the medical literature that medications like buprenorphine or naltrexone, disulfiram, these medications can save lives. And I like to make the analogy to classic medications. just the way aspirin can stop someone from having a heart attack or a stroke, buprenorphine dosed the right way can stop someone from dying just as equally. So that's where I come in as the physician. And if they are physiologically a little less unstable, right? The goal of these medications is to make you physiologically more stable in your human body. And these patients are not getting high off these meds. They're using it to sort of stabilize their physiologic state. And if that's stabilized, then maybe they can focus on their therapy and get more out of it from you. So if I do my part well, it gives you an opportunity to do your part well. There's an issue though, because most doctors are not trained to do my part well. It's crazy, but there's only a few thousand, because it is a younger specialty, there's only about 2,000 to 3,000 board certified addiction doctors in the entire United States. Okay. And there's 400 million people worldwide that deal with alcohol use disorder. There's another 80 million people worldwide that deal with other substance use disorders. We're talking about 500 million people worldwide with a B, and 3,000 addiction doctors in the wealthiest, largest country in the world. So there's this whole supply-demand thing going on, so it's important there's a part of these are the meds I have to give, and then the frequency, the dosage, doing it the right way. There's an art and a science to that, and education is key. Physicians are lifelong learners, so we're always learning new things of how to do things better, the right way. It's part of the process of doctoring.
Yeah, no, I've followed clients for years, in and out, some who've been in recovery, who've tried AA, don't want to try AA anymore, want to see how I can monitor, or can I monitor it? Can I come back and can we take it? And now I'm seeing more and more clients that are also dealing with marijuana or pot, and deciding to switch from alcohol to pot because they think that will work better. They often talk about stages of change. So as you deal with, and it is a chronic issue, and the medical support I think is really key. How do you assess or help remind a client, or watch them if you think they're sort of going off on a tangent? The person that I worked with for probably over 2 years finally discovered medication and went to meetings and was miraculously surprised at what a difference it suddenly made. But it was 2 years of going back and forth. How do you assess stages of change, and how do you walk through that with a client?
In our medical training, they teach us all the stages, and we have a sense of this. American Society of Addiction Medicine has levels of care of intensity based on a patient. So I use the American Society of Addiction Medicine's guidelines, and based on that, decide if this is something that can be done outpatient. Would it require more higher level inpatient or emergency care? So it's a spectrum. But Robert, I want to ask, so this is not your first rodeo, you've been doing this a long time. If you were to compare your patients who are on medication treatment and psychotherapy versus the ones who are not on medication treatment, just anecdotally, I know we're not talking about scientific papers and all this, but just experience matters to me as well, and you have a lot of it. What's your viewpoint? What do you think of because you've seen clients with both, right?
Yes, I think what you're talking about is right on, that medication with therapy and helping clients understand, break through their own stigma, their shame, helping them understand it is a medical issue in addition to psychological components, referring them to somebody who does understand that as well, and then being able to walk through that journey with them as they go through it, and make sure that I communicate, or we communicate, that there is not judgment here. Let's talk about your process and treatment, but your idea and your profession now as a board certified addiction specialist, I think is key. Traditionally, before this, we would send, or I would, the scope of practice was to send to a psychiatrist or a medical doctor to have the medical pieces taken care of first. Now, not everybody wants to go there right away, so I've sometimes had the patience to be able to work with them till they get there. But the two I think today for successful treatment have to go hand in hand. Otherwise, I don't think there's a lot of success.
And I really empathize with my psychiatry colleagues because treating the psychiatric condition is challenging enough. But to be able to be responsible to do the psychiatric and the addiction all in one, it is, correct me if I'm wrong, isn't that kind of difficult for the psychiatry? What would you say, Dr. Cullen? Is that difficult, or I really want to know the answer to that. As I,
I mean, is it difficult for me?
no. I mean, for the system, the healthcare system in general. I know not for you. I'm talking about the overall. You know what I mean? Like exactly. Yeah. Dr. Feldman can do anything. That's how good he is. But it's just more of a commentary of the systems. I'm talking more about systems, how it'd be cool if all the systems were aligned where it can be like cookie cutter and we can do all this. And I think, one of the reasons why mental health in physicians is also in such a fragile state right now, I think physicians are being asked to do more and more and more and more and more every single year with less and less and less and less resources. I think there's no denying that. And so that's kind of what I was trying to get at, if that makes sense.
I want to open it up to questions soon, but I have a couple more in terms of the issue of denial. I think because addiction, especially the physiology of it, is so different than what our rational minds know about it. It's very easy to say it's not that much of a problem, or I think I've got it under control. And then when you watch as your willpower or whatever you've tried doesn't work over and over and over again, yet the system, the addiction is so strong that you keep that fight. How do you help people break through that denial and just say, hey, this is a medical issue. I know it's going to be difficult for you to know, but I don't think you'll be able to continue to do this. I mean, there's 12-step meetings, there are inpatient, outpatient, there's medical doctors you can work with, there's talk psychotherapy. But I think key to that is helping the individual that you're dealing with understand the nature of it, especially I'm finding increasingly so sort of breaking through and not colluding with the client's denial, not sort of minimizing it or let them minimize it without pushing them away. Can you talk about that at all?
I think your profession is way better at that than my profession, to be honest. Because we're at such a time crunch sometimes with volume and charting, and it's really hard for the physician to do that part as well as the therapist, honestly. You know what I'm saying?
No, I appreciate that because it's for me, it is a longer process. And as much as we talk back and forth about it, it's sometimes letting that client hit the wall or hopefully hit it softly before the client that chose to finally get sober, take medication, and come off, did it because of a car accident, which was a significant price tag, which finally helped that person realize I can't monitor, I can't control it.
Yeah.
I have a price tag that's large enough. But that was over a 2 to 3 year period that we got to that point. So
there's that really good quote, have you heard that quote? Change happens when the pain of not doing something is greater than the pain of doing something, right?
Yes. Yeah.
So that's kind of one area of a thought of what people think is required for change to happen. The other side is, change happens when you have enough support from the physician, from your family members, from people who care about you. Change can happen from when things are so dire that it's time to now or never. But I'm a firm believer that change can also happen if you have love and empathy and support and evidence-based medicine and people who care about you. One of the great ER doctors who trained me, Dr. Billy Mallon, he said to me one time when I was learning about ER, he's like, Harut, you don't need to know a lot of stuff. You don't need to know a lot of SHIT, but you need to give a SHIT, you know, so it's you know what I'm saying? Like it's important to care. And that's important.
I think definitely the relationship, your relationship, our relationship is key to giving that person the space to understand with the unconditional positive regard that I'm here no matter what, and we can work through this. What do you see for the future going forward in the field, and what would be important for everybody here to know about what do we do next, or what do you think is coming? I appreciate what you said about medication, and actually was going to ask you too about how do we impress a client, because we're non-physicians, how do we impress them about what the medical model and implications are for addiction? I mean, I've read about the neurotransmitters, the opiate, the pleasure center, the process that fixes that, but it's difficult for me to really translate and help that. And a lot of people, when they hear about that, are surprised to know that it's not a moral issue, that I'm not going to judge you, that it's not a question of willpower, that there are multiple ways, that there is a chronicity about it. But how would you recommend we explain that, being non-physicians?
Well, you just explained it beautifully. That was really good. Just say what he said and you'll be fine. Yeah, you know, that's perfect. These people, these patients of ours, they suffer a lot, and they suffer. And a lot of them die very young. And there was a great podcast where, you know, the TED Talks. Have you guys heard of Gabor Mate? Yeah. I really like his talks. He's an interesting dude. He's also a physician. And he said this quote where it was from an Egyptian writer, I believe. Nothing records the effects of a sad life as graphically as the human body. It was really interesting. And as an emergency physician for the last 10 years, you know, I have seen a lot of suffering in my life. And there has to be a way that I probably process it as well, that I've been so busy, I probably haven't had a chance to even sit and think about it. But our patients with addiction, they suffer, they get infections, they get heart attacks, they get strokes, they get severe blood infections from injecting that goes into their heart and brain and their spinal cord. They lose their teeth, they lose their wealth, they lose their loved ones, they lose everything. And so just being someone who can care and try to help them not do that, I think that's a pretty cool thing that a doctor can do for a human being. You know what I'm saying?
Yeah, I think creating the compassion, the non-judgment, reminding them, letting them know what it is. I know we're running short or on time. One thing I wanted you to know, I had to track the good doctor down. He's apologized for getting back to me lately because I don't know, he had a baby in the process, and somehow that, in addition to his practice, was distracting him a little bit. But I do want to thank you for being here.
I want to give a quick shout. So my mom and dad and my wife are all here, right there. And so I would not be the human I am today without them. My mom and dad were immigrants who kind of put a lot of work. They worked, but I got, you know, a little bit of their work ethic from them. I'm not as hardworking as they are, but I got a lot of their work ethic, and they helped me actually build and start this clinic. I wouldn't have had it without them. So huge shout out to them for supporting me and all my crazy, wild dreams, you know, and my wife too, who I have 3 daughters. They're 5, 3, and 4 months. And, yeah, my girl dad is the best. You know, between 11 a.m. and 12 p.m., I was coaching girls basketball today. So I'm sorry, but it's been fun, and I really like being a dad and a husband and a child, I guess, to my parents. And you know, so it's all these roles we play. You know, we have all these roles and hats, and then you got to also be the doctor, and you know, so I really am. And you know, just one thing I also really wanted to mention, you know, a lot of physicians were so brave to speak about their mental health and dealing with suicide. when COVID hit, it was a very hard time for me as an emergency physician going into work. My wife was like 8.5 months pregnant in March of 2020. And I was going, I remember thinking like, I was still going to the ER in like a spacesuit. It was like the zombie apocalypse. And, one of the first physicians to commit suicide was an emergency physician and it really broke my heart. I do have physician patients who get ketamine therapy with me that do quite well. I think mental, we're human. And I just, it's important for the patients to know, we'll wear the white coat and we'll look all fresh but we are human too. And so I really have the mentality that we're all in it together, whether it's the doctor or the therapist or the nurse or the janitor or the case manager or the credential person, we're all in it together. So that's the only way we're going to fix stuff. You know what I'm saying?
Yeah, well, first of all, I guess now you reminded me I need to thank the individuals over here, your wife and your parents for the support. And much respect to all of you for supporting you, getting out here today and for the work you're doing. I do believe you're on the cutting edge. I believe it's key. I believe it's a component, what you shared about presenting a medical model, making sure that people understand that and taking away the judgment. Through my own journey of loss and healing, I discovered that. I discovered when I went through my own process and I was doing less than desirable recovery, what I spoke about here 7 years ago, less than desirable recovery sort of strategies. It dawned on me finally at this point in my career that people out there are doing their best. They're doing their best, and maybe the medication or the therapy is not working fast enough or well enough. So it caused me to really look at that idea that we do need to be loving, compassionate, and understanding and take that judgment away. And it's been that way ever since on my own journey. So I want to thank you. Do we have time for some questions?
I really want to thank all the therapists and psychiatrists for having me be here today. And like I said, I'm newer to this field and learning a lot, and I really appreciate it. It takes a team effort, and I'm really humbled and honored to be here speaking with all of you guys. Thank you again so much for the opportunity.
Hey, how are you? Thanks for your presentation.
Hey, how you doing?
Quick question. So I've run like a luxury drug rehab facility before in Malibu. And I know recently DHCS made some big changes as far as moving from that abstinence only model to harm reduction, and also like kind of forcing you to offer that to everyone. And like most rehabs hate that and they don't love doing that. So that's kind of shift. How do you see these changes at like a regulatory level? I don't know if anybody just gets impacting the future of addiction medicine.
Yeah, so I probably think health policy is going to shift towards a way where that is more incorporated in even settings such as residential rehab. And it just makes sense to offer it. I know there's a logistical standpoint that makes it more difficult, but I don't see any reason why it would hurt. What do you think, Dr. Paul?
Talking about harm reduction and change.
MAT and residential. Yes.
Well, harm reduction is risky, but sometimes you have to do it. I use it sometimes when I'm really exhausted and everything, but I have to document like for an extra 20 minutes because it's a risk. You're trusting the patient, and sometimes they betray that trust, and then you're really at risk. So it's a tough call.
I yield to the smarter, more experienced doctors. Thank you, Dr. Fulton.
Any other questions before we go?
2 questions
Okay.
online. The first one is, how do you support a youth who does not seem ready for change and or does not realize the negative impact that substances have on their day-to-day life?
it's very difficult, and I would reiterate that it's a journey, and it's going to take love, support, compassion, maybe medication treatment, depending on what the substance use disorder is, psychiatric treatment, therapy, all of it. And it's not going to happen in a day or a week or a month or a year. It's persistence, day after day, month after month, year after year. This is why this is a difficult chronic disease to treat. And I empathize if you have a child or a very young person dealing with substance use disorder, it's going to be a journey. It's going to be a journey. But that's when you have the most opportunity. The younger you can fix the substance use disorder, the more bang for your buck you're going to get long term. So taking it seriously, being with your loved one, and all those modalities are going to help.
No, I think it's excellent. I think it's similar between setting, what we call mom love and dad love. I want to accept you unconditionally, and there's a price. And I always believe, especially in the long-term strategy, that you continually plant the seed, and then you put up, you remind, you tell, and the biggest thing that you've spoken about today is reminding someone it's a medical issue. I need to get you to a doctor, and it's going to require therapy, and it's something we can't ignore.
And you can, there's a definition to addiction. You can define it to the patient, to that youthful person that's dealing with this. You can tell them that, we talk about the 4 C's: loss of control, being compulsive, consequences despite use and craving. I mean, those are kind of the definitions of addiction. So if you I like to define the words and not just label someone. And I incorporate that into my practice and try to explain to the patients, rather than saying, "Oh, you're addicted to this, right? You're an addict." We ask the patients, "Do you ever lose control because of using X, Y, Z? Right? Are you compulsive? Do you understand the consequences of what's happening? Do you crave the substance?" Those are sort of the big pillars of addiction that we think about, and asking those questions maybe can provide some insight to the patient. What do you think about that?
I agree totally. The assessments, I'm a certified addiction therapist for gambling out of UCLA, and the assessments are very similar to that. Defining the consequences, helping people understand what it means so they do get an understanding that it is a problem. It's not just a bad habit. It's not a moral issue. It's something now physiologically that's happening that you're losing control or have lost control over, and helping people understand that in those clear terms. It's great.
All right, we do have one last question. I thank you all for your questions. We do have our speakers here at the end of the conference if you'd like to shake hands and ask further questions or clarify any material. But we do have one more question we'll address, and we'll have our closing remarks. Last question is, based on your experience, do you believe overdose is strongly correlated more with suicide compared to accidental death?
Good question.
Wait a moment. Can you repeat the question one more time? I'm so sorry.
Based on your experience, do you believe overdose is strongly correlated more with suicide compared to accidental death?
I really don't know the answer to that question. I don't know. It's variable. There's both, obviously both happen. Which one is more strongly associated? I honestly cannot. I don't know the answer to that. Do you know the answer to that?
I don't think I know the answer. I think it would depend upon the substance. If we know that they're doing something that was associated with what we now know is a problem, an opiate addiction or something, would be more likely to be accidental than a deliberate ingestion of something that was pharmaceutical.
Yeah.
Would be my guess.
It's so individual. I did read the substance, the history, amount of use, what underlying psychiatric disorders they had. There's just so many variables. It would be almost impossible to answer that. I think, honestly.
I think that's it. Then I want to thank all of the people that presented today, but I'll let Dr. Feldman close us out here. But
Thank you so much. Thank you.
I just want to say thank you to Dr. Hovsepyan and Robert. Thank you for that talk, that discussion. That was really, very interesting, and thank you so much.